Bismillah ar-Rahman ar-Rahim. Welcome all colleagues and senior colleagues to the 10th week of Anaesthesia and Critical Care refresher course under Saving Lives Academy. It's my pleasure today to present three of the most senior colleagues dealing with today's lectures. Our session moderator today is Prof. Samir Al-Ansari. Our first speaker will be Prof. Salwa Al-Khattab. And our second speaker is Dr. Amr Salam. Prof. Samir, please go ahead and take over the session. Thanks so much.
Bismillah ar-Rahman ar-Rahim. Good evening, my dear colleague. Today we are going to discuss a very important topic, acute renal failure and its management, specifically the CRT and ICU. CRT is one of the important modality for renal replacement therapy, as you know, but sorry, it may not be available in each ICU. CRT is important. Why important? Because it is specifically indicated in some situations like hypercytokainemia, severe sepsis. In cases of even heart failure, we can using it in patient with hemodynamically unstable and you can't use hemodialysis, you can go ahead and use CRT. CRT depends on three principles in contrast to hemodialysis, as you will see now. It depends on concentration gradient, filtration, convection. Really, it needs a good and highly professional experience. And so we are going today to benefit from our professional, especially in this field, our professors, Dr. Salwa Khattab. She is a highly dedicated and eminent and conscientious professor of anesthesia and ICU in Ain Shams University. And she always actively participating in many medical scientific activity. And really, she is professional in both academic and clinical experience in ICU. Really, we are lucky today to share her experience in this field of how to manage acute renal failure, specifically with using CRT. Welcome, Dr. Salwa, and your mic is you.
Good evening, everybody. It's an honor to be with you today, sharing this nice and very useful activity. Thank you very much for Dr. Walid for inviting me and let me to participate in this very worthy activities. Dr. Samir, my professor, my mentor, thank you very much for this very nice presentation. Hope to be fruitful and useful to all intensive care practitioners to share this information. Our talk tonight will focus on a very, very important subject. As an intensivist all over the world, we are all facing this diagnosis and this problem in our patients, either as a part of our critically ill patient's problem or as an isolated problem, again, in a critically ill patient. Today, we will speak about acute kidney injury in a critical care settings and the management using continuous renal replacement therapy. Really, this is a very long subject, and we cannot cover all topics included under this very wide topic in 30 or 35 minutes. So actually we'll highlight a very important items, leaving this much more sophisticated and detailed topics for maybe further presentation next time, inshallah. Let us to start. We will speak today about acute kidney injury as an overview in a critically ill patient. About its prevalence in intensive care settings, either medical, surgical, or mixed. We will start with a real life case. It is a real case. We unit 65 years old lady She's otherwise healthy, presented with recurrent episodes of melena in the last week. And she also reported 2 episodes of passing fresh blood vomitus last 6 hours. A third episode of this fresh blood vomitus was while she was in ER. She gave a history of receiving diclofenac 25 milligram Q12 hour for the last 2 weeks to relieve a non-specific severe backache, and that much only as her past medical history. When she presented to ER, her heart rate was 130 beat per minute, blood pressure 90/40 millimeter mercury. She had mildly cold extremities. Anyway, she was fully conscious and oriented, and she reported to pass only 20 ml urine in the last 3 hours. 20 ml of urine only in the last 3 hours. What do you think to do for this lady as a first aid for her? Our colleague in ER sent her to us in ICU for immediate resuscitation, where we requested an urgent ABO-RH cross-matching, packed RBCs transfusion. She was given IV crystalloids, and full lab requested revealed her hemoglobin was 5.5 gram per deciliter. Her renal functions was high, UN 66 and creat 4.3 milligram per deciliter. Electrolytes was okay, and her blood gases showing metabolic acidosis with pH 7.3, CO2 26, and oxygenation was okay, and base excess of minus 10.7, and her serum lactate was 8.2. This is acute kidney injury. Acute kidney injury is an abrupt, which means over hours to days, abrupt diminution of the renal function with resultant in a retention of metabolic products. It's a nitrogenous metabolic products. And at the same time, there will be a dysregulation of extracellular volume and electrolytes, namely potassium and bicarb. Let us to go to our first question. The variation reported in the incidence of acute kidney injury that we are facing when we are reading a scientific paper. These different incidence and different prevalence, what do you think it is attributed to? What? To a different diagnostic criteria used, or to a different patient characteristics, or to a different geographical distribution, or all these causes might lead to different incidents that we are facing when we are facing acute kidney injury scientific publication. Yes, I agree very much. Yes, all these are the causes of this different prevalence that we are facing when we are reading about, sorry. Actually, AKI is a major public health problem. It is present over the whole, every country having this problem. It's a worldwide problem. Unfortunately, it's associated with increasing mortality and decreased survival. Unfortunately, once more, that being a critically ill patient adding more risk for AKI to occur and to lead to mortality. The incidence varies depending on definition used, on the cause, and on the patient settings, patient population studied. We can find it is from 1% to 20% in all hospitalized patients. 20% suffered AKI. This increased to be up to 67% when the patient studied in critical care areas, and mortality range from 10 to 80 depending on the patient population. Let us to go for another question so we can refresh our mind. What's true about the incidence of acute kidney injury in a new era of COVID? This correlates with the severity of illness. It is a rare coincidence with COVID, or AKI have no relation to mortality rate in a COVID. risk of AKI with COVID is higher in Chinese. What's true about having acute kidney injury while having COVID? 100% correct. I agree with this answer, of course. Actually, it's not only in COVID. AKI occurrence and outcome really correlate with the severity of illness. And COVID patients are sharing other patients in this issue. Patient with suspected or confirmed COVID may present with acute kidney injury. It might be a part of overall illness. They might present with a multi-organ dysfunction, and acute kidney injury is part of this multi-organ dysfunction. If it is present, it's usually happen within the first 24 hours of admission. This was found in almost 1/3 of the patients suffering AKI. 1/3 of the COVID patients suffering AKI were presented within the first 24 hours of their hospital admission. A lot of observations come from different countries. You know, with an era of COVID, we have a lot of publications and observational data. It can be from 3 to 37% of population hospitalized might presented with acute kidney injury. This, of course, different, very, very wide range. It differs according if the patient is severely ill or not, in a regular ward or an ICU. Also, and geographical location, have an access to early medical care or not. But of course, we are all agreeing it is higher in a critically ill patient. Dialysis was required in 15% of these patients from our observational study. And most of usually dialysis was required in the most severe patient, namely those on mechanical ventilation or maybe having hemodynamic instability. This study from this year about COVID pneumonia comes from single center experience in Bahrain. It is shared the same. The rate of AKI in their patient was high, as they stated, and it was strongly associated with disease severity, especially respiratory failure, and being mechanically ventilated, especially also if hemodynamically unstable. So again, AKI is correlated with severity of illness, and this the same for all patients, including COVID patients, and it is more common in a mechanically ventilated patient. And an independent predictors to suffer AKI in a COVID patient being older age, having comorbidities, diabetic, hypertensive, cardiac disease, and mechanically ventilated. Actually, the mechanism is not that much clear. Is it a direct viral nephrotoxicity, or more acceptable theory about part of hemodynamic instability, and might be a host response in the form of cytokine release syndrome? This nice diagram showed the possible mechanisms of acute kidney injury in a COVID patient. It might be direct hypercoagulability produced by the infection, which can directly affect the kidney, or affect the kidney secondary to affection of the heart or to affection of the lung. It might be a direct endothelial damage, or secondary again to cardiac affection or pulmonary affection. It might be also a part of cytokine release syndrome hitting the kidney as a part of its effect on the multiple organs in the body. It might be secondary to ARDS and a part of multi-organ dysfunction, especially if the patient got sepsis and became a victim of multi-organ failure syndrome. About classification systems, as we mentioned before, we have different definitions and different stratification or classification systems for acute kidney injury, and this make us having a problem, not unifying a one definition or a single criteria to be agreed for diagnosis and stratifying risks in the acute kidney injury, especially in critically ill. a lot of classification systems and definition system were present. The most important were three. Let us to go to this question. What shared criteria between most of the most common classification systems? As we mentioned, there are many classification systems. What do you think about the most shared criteria? Is it base deficit? Is it the history of being chronic kidney disease? It's the urine output and changes happen in the urine output, or having cardiac decompensation. What is the most shared criteria for diagnosis of AKI in most of these systems? Yes, agree, of course. As we will see soon, urine output is the most shared criteria. The change in the urine output is very important criteria to identify and stratify patient with AKI. Let us to start with the Rifle criteria. Rifle criteria developed 2002 by Acute Dialysis Quality Initiative group who made to find a unified definition for the AKI. It's based on urine output here and GFR or serum creatinine, and they identify 7 days for these changes to diagnose AKI. And this criteria having 3 grades between risk of having AKI or injury of the kidney or failure. And it's also comprised 2 outcomes: loss of the kidney function and end-stage renal disease. This is test for Rifle. Rifle, risk, injury, failure, loss, and end-stage renal disease. You have to, or you can diagnose acute kidney injury by one of the criteria, either in the urine output and or in the serum creatinine change. With this criteria, you can put the patient either in the risk of acute kidney injury or the injury itself, or in the failure, and you might diagnose loss or end-stage renal disease. It's very useful criteria with sensitivity to identifying patient at risk. Later on, an acute kidney injury network, they published another criteria. It's not like Rifle, identifying risk, injury, failure, but it is stages, stage 1, 2, 3. Failure comes in stage 3, or failure of like Rifle comes like stage 3 in acute kidney injury. It is similar to Rifle in some items and differ. Here the duration to diagnose is 48 hours instead of 7 days in Rifle criteria. And they don't have, they are not using GFR, and there is no loss or end-stage renal disease, or comes under stage 3. It is similar Rifle criteria as regard urine output, serum creat, in addition to increasing serum creat by more than equal or more than 0.3 milligram per deciliter. This increment is considered as abnormal. Another and the most recent classification is KDIGO. It's kidney disease improving outcome. Sorry for this mistake in this abbreviation. It is kidney disease improving outcome. It's similar to acute kidney injury network classification of being using increasing serum creat by more than 0.3 milligram per deciliter, again 48 hours, and it's using Rifle serum creatinine value within 7 days, urine output less than 0.5 ml per kg per hour for more than 6 hours. So as we see, they are sharing some of the criteria. Let us to see all together. This slide, we can see that urine output criteria are shared between the 3 classification systems, as you mentioned before, and the changes in the serum creat level is the one differ from one to another, and in the same time the duration. So when we are mentioning prevalence or incidence of acute kidney injury, we have to tell what criteria we are using to diagnose or classify the patient, so we can compare it properly. Let us to go to our case, back again to the same case. in this patient with serum creat 4.3 milligram per deciliter for the first time before she was normal, and urine output of being 20 ml per hour, 20 ml per the last 3 hours. Do you think this patient can classify as acute kidney injury? As what criteria? Rifle, acute kidney injury network, or kidney disease improving global? Let us to highlight some etiologies. What is the most common cause of acute kidney injury in your opinion, if we are speaking about critical care patient? Is it hepatorenal syndrome? It is obstructive uropathy, or pre-renal cause of acute kidney injury, or it's a cardiorenal syndrome? As you are working in intensive care, what's the most common you are seeing? Yes, pre-renal causes are the most common. It's almost 65 to 75 of AKI occur in hospitals are pre-renal. And it's shared between pre-renal and intrinsic acute tubular necrosis, or ATN. It can cause by a lot of causes, as you know, with a risk factor, again, as we mentioned before, being aged person, having sepsis, being post-operative, especially for cardiac surgery, receiving nephrotoxic medications, having diabetes, hypertension, or a pre-existed renal disease. About pre-renal, it can be can result from impaired renal blood flow, which, if not treated properly and immediately, it might proceed to be acute tubular necrosis. This happened usually in shock patients. Either the shock is hemorrhagic, hypovolemic, or most commonly septic, and decrease effective circulation. Some medications lead to pre-renal through its decreasing renal blood flow by working in the tone of afferent arteriole or intraglomerular hemodynamic alteration. It's not that much common. The most common of being shocked, like our case. Intrinsic acute kidney injury, the second most common cause, it might be injury of the renal tubules itself, vascular structure, glomeruli, or interstitium, or tubular obstruction. In ICU, there are many other reasons. It's not that much common like pre-renal, but still we are facing in a critical care setting hepatorenal syndrome, which is an intense renal vasoconstriction, while we have peripheral universal vasodilatation, arterial vasodilatation. The cardiorenal syndrome, which is a triad of decreasing kidney injury, diuretic resistance, heart failure, and worsening of renal function during heart failure therapy. Tumor lysis syndrome also might present with AKI, and of course, we know all of us, we might face this contrast-induced nephropathy. What to do to manage our AKI patients in a critical care setting? First of all, you have to search for the cause which precipitates this illness, if it is present, and manage it. Revert the cause, you might have improvement in the condition. Like in our case, this lady came with hemorrhagic shock. She was having hematemesis and melena, and she was almost hypotensive, going to be shocked. And I'm thinking replacement of her blood loss and working with this hemorrhage will improve her condition. So if you have a problem with the pre-renal, think about volume replacement, and don't ever forget nephrotoxic medication. We have to stage severity of the patient, like what we said before regarding the criteria, either rifle or other criteria, so we can tell where we are from risk or failure or injury. We are in a severe form or not severe form. We are where we are, I mean, stratifying the risk again. And according to the stage and the cause, the plan will be set for managing this patient. And after resolution of the acute condition, I'm thinking our colleagues, nephrologists, will evaluate the patient later for possible complete resolution, a newly recurrent onset of AKI once more, or they are went into CKD and might be end-stage renal disease. It's our case once more. And where, what about the management? The management, first of all, to manage the cause of this bleeding and hypovolemic shock. What about acute kidney injury in COVID patient? Is there any change if we are not going to dialyze the patient or putting the patient on renal replacement therapy? It will follow the same lines of management. The only limitation is that we cannot provide a liberal fluid management in a COVID patient. We have to be more conservative in giving fluid, especially in a pre-renal AKI. Why? Because it was found that a conservative management of fluids in these patients is vital to preserve or to enhance recovery of the respiratory illness. So we have to individualize, again, the patient needs and response to fluid and manage this in a wise way. Another question, what do you think about the indication of urgent renal replacement therapy in acute kidney injury? Is it severe hemodynamic instability, or being the patient having a coagulopathy, which is uncontrolled, and he is a chronic kidney disease patient, refractory hypoxia in patient who is chronic kidney disease, or being volume overloaded with resistance to diuretic effect? What will push us to go emergently to renal replacement therapy? Yes, being hemodynamic instability, it might delay going to RRT. Coagulopathy is, yes, it might be a pushing cause to go for dialysis, so we can infuse more plasma and other coagulation factor, but it's not an emergency indication. But volume overload, which is no more respond to diuretics, is a real indication for going to urgent RRT. So if we are not happy about the conservative management of acute kidney injury, we have to go for renal replacement therapy. And I am also putting a slide of continuous renal replacement therapy. This will be the most, actually, it will be, we will highlight the continuous renal replacement therapy tonight more, because we are speaking about critically ill patient, as this is the most preferred model in critically ill patient. What is the indication? When to go for RRT? What to do? What is the modality? How much the dose? And when to terminate, or for how long we will go for RRT? When to initiate renal replacement therapy? It is a real mess. When to initiate, it's a very big question. It's a matter of controversy. Let us to go early or wait. It is better to be delayed renal replacement therapy. There is a lot of controversy and a lot of discussion about early versus late. Usually we are using biomarkers or parameters to tell early versus late. It might be biomarkers about renal functions, electrolyte, and so on, or clinical markers, or the time from presentation of the patient till the decision to make to go for RRT. There is an absolute, and these are urgent indication for RRT. Once it's present, there is no discussion. We will go for RRT and to save the patient life, like what we tell now, refractory fluid overload. Refractory means no more responding to diuretics, severe electrolyte disturbance, namely hyperkalemia, or rapidly rising potassium level, again not responding to anti-hyperkalemic measures, azotemia, uremia, pericarditis, encephalopathy, or severe metabolic acidosis, not responding to conservative management, and some drug intoxication and alcohol intoxication, we might necessitate to go soon to dialysis. These are one of the most common, actually, when we are searching literature, the hundreds of studies about the time of initiation of RRT. The most famous are three studies, or these two studies, AKI, this from France, 2016, and the other one is ELAIN, it is from Germany. The first one is considering a surgical critically ill patient, post-operative, especially post-cardiac. The other one was conducted in medical ICU. They are not using the same identifying and criteria. The first study used KDIGO stage 2, while the other one KDIGO stage 3. And they are studying RRT with different, the intervention for the first study within less 8 hours of acute kidney injury, and it's considered to be delayed if they are waiting till 12 hours. The other one considering early is a 6 hour, and the other, or if late, which means there is an urgent indication to start RRT. The last study used 12 hour and more than 48 hour, 12 hour, less than 12 hour as an early start, and more than 48 hour as a late start. This ideal ICU study was conducted in a septic patient species. It's a multi-center once more. Mortality was measured like 90 days mortality, 60 days mortality, or 90 days much more. Akiki study, the France study, French one, was found no significant difference of being early versus delayed in starting RRT in acute kidney injury. It is not different in the outcome as regard mortality. The other two studies, also the ideal ICU study, show no significant difference in 90 days mortality between early and delayed strategy of renal replacement therapy. While the Elaine study showed that early compared to delayed initiation of RRT was associated with less mortality. This study about optimization of optimal timing of initiation of continuous renal replacement therapy in septic shock patients. It's a retrospective study, was in North Korea, including 158 septic patients. And they found that the time limit was 16.5 hours from onset of presentation of the patient till RRT was associated with a better outcome. They found this as a retrospective studying their patients, and still they are recommending further studies. What is versus early versus late? Our guidelines show that you should not consider a cut-off biomarkers, but you have to look to the whole clinical context of the patient. If you have emergent indication to start, you have to start immediately without any delay, as we mentioned before. If you don't have these emergent indication for RRT, you have to consider the whole clinical context of the patient. If there is a modified or a reversible causes, you can work with the trends of renal functions and other biomarkers and clinical data and laboratory tests, urine output, clinical condition of the patient or not. And this, again, one of the recommendation of being a multidisciplinary opinion. The intensivist together with the nephrologist, you have to discuss, is it okay to start now or better to delay if there is still a chance to improve the condition of the patient. Renal replacement therapy have different modality. It is actually you are speaking an a hemodialysis with different modality. We might have continuous, we might have intermittent, or we might have a slow or extended dialysis. The classic speaking is intermittent hemodialysis, and which modified to be slow or extended dialysis for some patients. And a new one, or the most advanced one, is being continuous over the 24 hours. There are a complementary modalities. You can start with one and shift to another if there is an indication. This depends on the patient condition and depends on your infrastructure and your capabilities in your institute. What's the infrastructure you have, what are the resources you have, and the level of training of the personnel, physicians and nurses, and of course your equipment. CRRT is, generally speaking, preferred in unstable patients. So it is a modality of preference for critically ill patients, especially those on hemodynamic support or hemodynamically unstable. Why? Because it makes the changes at slower rate, and so the hemodynamics can be maintained, and so we can dialyze the patient over 24 hours, getting the best outcome without putting the patient in a jeopardized hemodynamics. It's another modality which is sustained low efficacy dialysis. This is a modification of intermittent hemodialysis. It can consider in multi-organ failure, and it's good as regards providing better hemodynamic stability in comparison to intermittent one, while at the same time using the same resources, the same machine, and same training. No need for extra resources and more expenses if it is not available. Actually, there's no evidence to demonstrate mortality difference between all these modalities, and our guidelines recommend the use of CRRT whenever possible, whenever available for hemodynamically unstable, and you can also intermittent hemodialysis as a complementary therapy. This is a very nice table comparing three of them. Intermittent, the cost is the least, while the CRRT, the cost is the highest. The duration, intermittent usually 3 to 4 hours. It is 24-hour and continuous one, while it is for the extended up to 12 hours. The hemodynamic instability is the highest in continuous. Next will be for the slow, extended, and the least for intermittent. Anticoagulation can be used for all or omitted in certain situations, and the efficacy of dialysis and removing the metabolites is the highest for intermittent and the least for continuous. It takes time to get the benefit. Mobilization, of course, is much better with intermittent, while in continuous the patient will be bed bound in critical care area. What is the principle for extracorporeal RRT? We have different principles using renal replacement therapy, whatever the modality, either by diffusion or by ultrafiltration, convection, or adsorption. What is the dose of renal replacement therapy? How much we have to dialyze our patient. The adequate dose can be presented by the volume of blood purified per unit of time. Traditionally, you are using the purification of urea. And an effluent rate is the surrogate for this. So the effluent rate, which is the rate of ultrafiltrate in case of hemofiltration, and or dialysate if we are dialyzing the patient, or both of them if we are running hemodiafiltration. The usual dose is about 35 ml per kg per hour. Some were recommending 60 or more than 60, which is very high, or low like 20, and still it's not the usual. The usual is 35. Our guidelines setting that in clinical practice, to achieve delivered dose of 20 to 25 ml per kg per hour, we have to set the rate as like 25 to 30. Actually, this is speaking about continuous renal replacement therapy. In continuous renal replacement therapy, it's continuous, supposed to be over the 24-hour, but in the real life, it is many times interrupted. The patient can go for CT, the patient might send to OR for some surgical interference, or might be for any procedure. So there may be many times interruption of the continuous renal replacement therapy. So considering these many times interruption, the dose needed to be implemented 25 or 30 ml per kg per hour, but this actually to cover the interruption. So we are really to provide 20 to 25 ml per kg per hour. This is the least needed. When to terminate our continuous, it's again for continuous renal replacement therapy. You are speaking on continuous renal replacement therapy. When to tell it's enough, we are good, let us to stop what we are doing. According to the guidelines, if there is a recovery of the intrinsic kidney function, actually many AKIs are reversible. And so the kidney function might recover, and we have to catch this moment and to stop renal replacement therapy and to give the patient the chance to work by his own kidney. This might be by how to judge this. We can judge this by the urine output. We can judge this with a lot of biomarkers, and so we can give the patient chance to work with his own kidney function to meet his goals. The guidelines was not recommending very much using of diuretics to enhance kidney function recovery or to reduce the duration and frequency of RRT. It's not recommended to have diuretic for this. Some reliable parameters to terminate or to stop continuous renal replacement therapy is the improvement in urine output, being more than 500 per 24 hour, usually without diuretics, with no volume overload. The daily decreasing trend of urea and creatinine, and of course of vasopressors. You might shift from continuous to intermittent if the patient is still in need, no more need for continuous, or if the patient left the ICU. Let us to have a highlight on our continuous renal replacement therapy. We will not go very much deep, but it might be helpful. It started in 1977 by a German physician, Peter Kramer. He was using at that time mean arterial pressure to create this difference to push blood to the extracorporeal machine. Later on, 1987, from Canada, Peter Rupert introduced the continuous venous hemofiltration by using pump. Actually, this was not met. This was he was trying to introduce a vascular venous catheter. Inadvertently, it was arterial, and later on he thought about putting a pump, and this was the initiation of the most recently advanced chronic continuous renal replacement therapy. These are the modality: slow continuous ultrafiltration, or continuous veno-venous hemofiltration, or continuous veno-venous hemodialysis, or continuous veno-venous hemodiafiltration, which is the most commonly used modality. Anticoagulation is used to avoid clotting of the blood while passing through the dialyzer or the membrane, which will shorten the membrane life and leads to loss of blood. And this is loss of blood, loss of resources. It aims to keep this dialyzer patent, allowing for prolonged time or prolonging the lifespan of the dialyzer while we are dialyzing the patient in a continuous over 24-hour manner. There is another, you might use unfractionated heparin. This is most common, or low molecular weight heparin. You might use also what's called regional citrate anticoagulant. This is the most recent, and this is what was recommended by the guidelines. We might use it locally to the circuits, pre-circuit, or you might use it systemic, and this is not that much recommended. But we can tell our colleague, or we can work in ICU with no anticoagulant. We are telling we need heparin-free dialysis, for example, to our colleague in intermittent hemodialysis. If they have any coagulopathy, thrombocytopenia, or we are at risk of developing major hemorrhage. This is a diagrammatic diagram showing continuous veno-venous hemofiltration. actually the patient having his hemodialysis catheter here, and we are withdrawing the blood by a pump from the patient with a certain blood, and the filter, which is a multiple hollow fibers. The blood passes through these hollow fibers. It is an extracorporeal filter, and then the blood, there is a pump pressure applied to the filter, so we can ultrafiltrate the patient. Some excess fluid and might be with excess solutes will come out as effluent, this to be drained, and the purified blood will be back to the patient through the venous limb of his dialysis catheter. We might add a replacement fluid to replace some of these lost fluids and solutes, or not, according to the prescription of our continuous venous hemofiltration. This relies on a principle of convection, and it removes solutes, which is small and medium-sized solutes, from 10,000 to 20,000 Dalton. The final plasma concentration of these solutes will depend on the concentration in the replacement fluid. Actually, we are pushing these solutes. It will come out by convection principle, dragged out of the patient blood with fluids, and the replacement, we might need to replace these solutes, might be sodium, potassium, urea, like that. If we are going to dialysis, you have to put dialysate. Dialysate is the fluid containing less concentration of some electrolytes, and zero, of course, in urea and create. It depends on the diffusion principle. Dialysate will pass through the filter in a in a reverse direction of the blood. By diffusion, the higher urea and create in the patient blood will exchange with the no or low concentration in the dialysate, and then this will be drained as if once more. In dialysis, you are only exchanging solutes with principle of diffusion, and if no ultrafiltration added, there will no fluid removed. But if you add fluid, hemodiafiltration, and there will be a dialysate and also replacement fluid, you will wash the blood out of solutes by dialysate. This is a diffusion, and excess water with some other solutes with ultrafiltration. This is a convection and ultrafiltration. This is the most commonly used and invented continuously in our critically ill patients. And this is the diagram showing 3 modalities, one with only replacement fluid, and we are getting out fluid together with some solutes, and the replacement to either pre or post dilutional, pre-filter or post-filter, or we are putting dialysate, so we can dialyze the patient and getting rid of getting rid of extra urea and create, and you might combine these together, going to a continuous venous hemodiafiltration. What is the modality to select? This depends on your patient. If your patient is volume overloaded, you might need only ultrafiltration. To reduce, you have hypercapnia. In hypercapnia load patients, implement continuous renal replacement therapy. Access is needed. Catheter, a hemodialysis machine. This is a designated machine. You have to have within this machine the membrane dialyzer and the connections, of course. You have to have a substitution or replacement fluid, and you might need anticoagulation. A diagram again to show our vascular access is very important, and it is one of the cornerstone to for the success of your continuous renal replacement therapy in your critically ill patient. You have to achieve adequate blood flow. You have to minimize at the same time for the risk of infection and mechanical obstruction, and making efficient replacement. This is pictures for our requirements: the catheter, the membrane dialyzer, the machine, and the fluid bags. When we are prescribing CRRT order, it might be by the nephrologist, it might be by the intensivist, or it might be by both of them. This depends on an institute protocol. Each institute should have his own, their own policy and protocols. Who is the one responsible for prescription of CRRT? You have to assign the dose and the fluid balance needed, and the blood flow rate, modality, access, dialysate rate, and like that. If you will use anticoagulant, yes or no, the dose and where to use it, pre-dilutional, before the filter or after. And this is a table to compare the different modalities in the prescription. And this is a nice flow chart used in some institutes for patients on CRRT. This is the task of intensive care nurse. What is the complication of CRRT, like intermittent hemodialysis, the vascular access, the anticoagulation, the metabolic complication, hemodynamic instability, still a risk, even it's much less than intermittent one. What about AKI receiving CRRT in a COVID patient? Again, we have to stick to your policies and protocols, and you have to minimize the risk of exposure, very much exposure. All infection control parameters should be implemented. Still, CRRT the preferred for the critically ill patient, but we have to consider that it exposes the nurses and staff much more than if it is intermittent hemodialysis. Again, minimize exposure and implement all infection control parameters. Peritoneal dialysis, we have to mention it in some situations, especially in the era of COVID, where resources were a problem. It utilized peritoneum as the membrane to exchange, and it was the only tool for the old days. But currently, with the automated recycler and some new advances, it comes again to be an option. So in areas with overwhelming cases and overwhelming needs for dialysis, peritoneal dialysis can solve the problem of lack of resources. We have to have, and this is can be for a topic for several lectures, it's the issue of drug dosing in acute kidney injury. We have to think about the dose of our patient, those receiving dialysis or not. And for those receiving dialysis, it's different of being on intermittent versus being on continuous. It is a lot of information we have to gather. Again, this is a very important area for multidisciplinary approach together, intensivist, clinical pharmacist, and nephrologist. Actually, I cannot go deep in this. It needs another occasion, maybe different lectures, but this is a very important issue. Drug dosing in acute kidney injury and in the patient receiving hemodialysis, intermittent versus continuous. You have to have to use some formulas to check about clearance, either the innate clearance of the patient by his own kidney and together with the hemodialysis machine. This is very important part. Unfortunately, it's overlooked in in many situations. The nutrition. The patient with acute kidney injury usually suffering a nutritional problem, and he or she is in need for a good nutritional support, so to get a proper, a good outcome. You have to think about the original cause of the patient, which might be a hypercatabolic condition like sepsis, for example, like burn, like trauma, multi-organ dysfunction. You have to nourish the patient. You have to provide adequate calories. As regard protein and acute kidney injury, the current trend is not that to limit that much. You have to give properly to improve the patient response to medications and outcome, but consider in that the sum of amino acid solutions commercially present, parenteral amino acid solution might be a source of potassium. If you have a problem with the potassium, you have to think about this very much. Amino acid should be provided for the patient, either supplementary with the enteral or oral feeding, especially if the patient on continuous renal replacement therapy, because amino acids are lost in dialysis. So you have to replace. These are some of the suggested requirements, nutrition requirements for the patients with acute kidney injury and dialysis. It's very important. You have to think about your nutritional support plan. It is very important task for the intensive. This is our topic today. I'm thinking it's very, very, very big to cover everything in one lecture. But at least we have some messages to take home, that acute kidney injury is a common presentation in our patient. The difference in definition and the risk stratification system makes us in dilemma. You have to tell what definition you are using. You have to understand the patient's clinical context and the trends of his laboratory data and clinical data, so you can tell when he or she will be in need for renal replacement therapy or when to continue for your conservative measures. It is a state of art what's modality to be used, especially in a critically ill patient with borderline hemodynamics or maybe jeopardized hemodynamics. COVID is a real risk for AKI, and there is no too much changes between the management in COVID versus the management of the normal non-COVID patient. Keep eye on nutrition, keep eye on drug dosing, and keep eye, consider a multidisciplinary approach. This is the key for success in such patients. Thank you very much.
Thank you, Dr. Salwa, for your nice presentation, intensive lecture and informative. And really, I am pushed from Dr. Walid. We need another 2 or 3 lectures to share your experience in this field. Really, you is a professional one in this field, I know. We have many questions here, but I will select some of it because of time being way over. Precautions before contrast injection in acute kidney injury or in acute kidney impairment.
Actually, currently the most common and the most efficient is to keep a patient well hydrated. It's keeping the patient well hydrated. Even the bicarb that we were using before, we are not believing very much. And keep your patient well hydrated. Use it only when indicated. When indicated, because sometimes you are rushing to this. Maybe other alternatives are present.
About the difference between hemofiltration and hemodialysis. Hemodialysis.
Hemofiltration using the concept or the principle of convection. Actually, we are applying a pressure to the blood while passing. It's hydrostatic pressure while passing through the filter, and this under this hydrostatic pressure or pressure difference, water is coming out, dragging solutes with this water. So we are getting rid of water and solutes. Some solutes, of course, not that much. It's mainly for water and so for fluid overload. And you have to replace the patient with a fluid. It's a replacement fluid if you wish to keep a certain limit for these losses, because you cannot judge how much electrolytes and solids will be removed. So the final level of serum electrolytes depends on what you are replacing. In dialysis, it's nothing. It's diffusion. The solutes, namely urea and create, moves across its concentration gradient. The blood passed by the filter in the reverse direction, the dialysate. Dialysate is 0 concentration. Blood is full of metabolites. So metabolites moves across concentration gradient from blood to dialysate. Nothing more. So if you have a metabolic problem, go for dialysis. If you have a volume overload problem, go for hemofiltration. If you have both, you have to go for hemodiafiltration.
for antibiotic adjustment, both in acute and chronic kidney disease?
Actually, no. This is a very big issue, and it needs maybe 2 or 3 lectures. You have to think about your drug pharmacokinetic. If there increasing volume of distribution, and this is what the situation in acute kidney injury, usually you are facing increasing volume of distribution. So you have to give a loading dose. If you are not giving a loading dose, you have to give a loading dose so you can reach satisfactory initial serum level of your antibiotic. Or if you are giving a loading dose, you might need to increase loading dose. Volume of distribution can be calculated. At the same time, if your drug is dialyzable or not dialyzable, this is different. For intermittent, of course, we are giving dialyzable medications post-session, post-hemodialysis, or you might give an extra dose, supplementary dose. It needs to think about pharmacodynamic, pharmacokinetic. You have to go to drug information published by the manufacturer. But you have to calculate your clearance. What you know, we have to know the clearance provided by your RRT modality, either intermittent or continuous. And if there is still some own patient kidney, some clearance, getting this clearance and calculate the dose as per manufacturer recommendation. One of the most important and most helpful in some medication using therapeutic drug monitoring. Vancomycin, aminoglycoside, you can measure serum level and adjust your dose accordingly. So it is a wide,
according to pharmacokinetic, yes, as you said.
Yes, yes.
I think we have to stop questions here because of time and because time is limited now. Thank you, Dr. Salwa.
Thank you very much.
Nice and intensive presentation. Thank you.
Thank you.
So it's my pleasure to introduce Dr. Amr Salam here, my colleague in Ireland. He is actually a lecturer in Ain Shams University and was a neuroanesthesia fellow in Beaumont University Hospital in the last year. And so he is combining between the Irish experience and Ain Shams experience. And when he talks about neurosurgery, that's the area of his expertise and his interest. Most interested in neuroanesthesia. So when we are talking about complex spinal surgeries, he's one of the right persons to talk to you about that. So Dr. Amr Salam, please go ahead. Thank you.
Thank you very much, Dr. Walid. Thank you very much, Dr. Salwa, for the nice and lovely presentation. Thank you, Dr. Samir, as well, for your moderation. We're going to talk today about anesthesia for complex spine surgery. And here, complexity in spine surgery is a relative term. What is complex and what's not? But like we can conclude that any revision to prior back or spine surgery might be complex. Scoliosis surgery or corrective surgeries is also, but we can conclude that any type of surgery that involves any major deformities or major curvature correction or spinal tumors or trauma. Stanford University Hospital developed this classification for its own practice, just to determine what IV axis, what supposed to operative destination the patient would be sent, and it shows each and what the estimated blood loss as well. It's not recognized, but I find it very nice and clear, and it clears everything for us. When we gonna discuss about any patient and we prepare our patient for the surgery, especially complex spine surgery, we mainly, I think, about 3 main points: pediatric and for adolescents. Corrective surgery is the commonest with the scoliosis, which is with the respiratory and cardiovascular sequelae and effects on the whole system, or either a spinal bifida correction with the autonomic dysfunction and autonomic dysreflexia that will happen. While in adults, we expect more like an autoimmune diseases like rheumatoid arthritis, or even a degenerative disease like osteoarthritis, that with all of its sequelae and all of that affection of the old age people involved in that systems. While if we talk about the surgical approach or the level of the involvement of the surgery, So I think just it will jump to you, like if you are discussing a cervical surgery, so incubation is a very critical, importance here, has a very critical importance, and has to be discussed and planned as we will talk. And the involvement of the great vessels and the nerves and the delicate structure in the neck, if we're approaching that from anterior. While in thoracic surgeries, most difficult thing is the ventilation. Is it a one lung ventilation using a double lumen, or just a one lung ventilation with a simple tube and a little bit of pressure that we require more inflation? And positioning as well, either it's lateral or an anterior approach or a posterior approach, or alternating, which is a major thing, and has to plan, and we have to plan that for weeks and to train the whole team for that. And for lumbar procedure, I find the most critical thing is proning, and we will talk a lot about proning in this lecture because it's one of the most critical things. And then the last thing is any specific monitoring required. I'm talking here about the invasiveness of the monitors. Is it like a cardiac output monitors? Arterial blood gases is something like a standard now for the whole complex or major spine surgery. But neuromuscular monitoring is evolving. It happens a lot with a lot of surgeries, not either the scoliosis or corrective surgery. We had loads of surgeries that require neurophysiological monitoring, and that will require some specific consideration in our anesthetics. So let's discuss about the patient and what we will prepare, how we are preparing this patient, and what's the preoperative optimization. And I'd like to discuss that in a major 5 points. These 5 points have to be reminded, and I remind them like that. So first of all, it's airway evaluation. Airway management for these patients presenting for spine surgery, specifically, of course, cervical or upper thoracic surgery, should be planned well. The patient should be examined promptly, and the patient may present with a disease or that destroys the airway itself, like rheumatoid arthritis with involvement of the jaw movement or the neck itself. Rheumatoid arthritis need to be a cervical surgery, but you still have to be considered a lot about the whole airway and how the planning is for that. The other thing is the pulmonary evaluation for these patients. And pulmonary evaluation for this patient, our minds will jump directly to the Cobb's angle for a scoliosis, but it's not the only thing. Assessment for pulmonary evaluation for these patients is very important, especially for a kypho and scoliotic surgery, because that might lead to some sort of restrictive lung pathology, and that will subsequently lead to cor pulmonale and pulmonary hypertension. But still, other diseases and old age as well might present with a COPD or a Kaplan nodular rheumatoid arthritis affecting the lungs as well. All of these might lead to some sort of complications through the pulmonary system. It must be evaluated. Pulmonary function testing and arterial blood gas analysis as well should be considered, especially in thoracic surgery if we are planning to one lung ventilation. Do we think that the patient will tolerate one lung ventilation or not? And that will predict the effects of the one lung ventilation and thereby the surgical approach. We might decline a lateral approach or a thoracotomy for a patient because they don't have any pulmonary reserve. Cardiovascular evaluation for scoliosis with the pulmonary hypertension and cor pulmonale. But systemic hypertension, rheumatoid arthritis might cause some sort of heart block as well. The other tricky point in these patients, that these patients presenting for spine surgery usually are unable to exercise and cannot provide any proper functional assessment. So most spine surgery as well is performed in a prone position, which is associated with a reduction of cardiac index between 12 to 24%. Compared with the spine. That's a result reduction of the venous return and the left ventricular compliance. The last 2 points in preoperative evaluation of these patients in the musculoskeletal evaluation and the neuromuscular evaluation. And these are very important because we are presenting to elective case, hopefully. Trauma, yes, it's emergency or urgent, but like we still have time to evaluate our patients. Some of the patients having spine surgery have coexisting conditions that make surgical positioning challenging, and we have to plan that. It's not a very easy thing to present during the surgery. You are able, the patient has a limited shoulder mobility, and you are not able to put him in a prone with his hand beside his head. That may make a lot of things difficult, and you have to assess that as well. And the neuromuscular evaluation, it's mainly for the anesthetist safety. Existing motor and sensory neurologic deficit should be recognized and documented prior to the surgery. Knowledge of the existing deficit will give, especially after intubation in a cervical spine instability, for example. Then after we finish the evaluation, now we are for the next step, which is the lab investigation. And existing comorbidities and invasiveness of the surgery, that will help and should dedicate the preoperative laboratory evaluation you are. And then the most important thing I think about is the pre-medication itself. And that will lead us to the first question. What do you think about what's on the best evidence, which is the pre-medication you would suggest for an ACDF, which is an anterior cervical disc fixation of 3 levels, which is a major surgery? Is it a 5 milligrams of midazolam, 5 milligrams of morphine, a hyoscine patch, an oral pantoprazole 40 milligram, or an oral gabapentin? Yeah, so it wasn't conclusive answer, and I totally agree. And like according to the best evidence, gabapentin is the only the medication that's proven that has an efficiency for post-operative pain for and the opioid consumption. We have been using midazolam and morphine for the stress of the patient and helping, but that might hinder their pulmonary functions if there is any some sort of restrictive pathology. While for hyoscine patch, if you are planning for an awake fiber optic, yes, that might be helpful. Other than that, it won't be any useful. Actually, the last two, that's the one I used to use. The gabapentin is mainly with the evidence that will be shown now. This is a meta-analysis that's published in 2017 about the efficacy of preoperative gabapentin, which is a very nice, and it shows like about 10 trials involving 800 patients. And all of the studies suggest that administration of gabapentin is effective in reducing postoperative opioid consumption and the VAS scores for pain scoring, and even the some side effects of the spinal surgery itself. While this meta-analysis, the network meta-analysis, is to assess the dosage itself. It varies between 300 and 900 milligrams. And the end result is there is a dose-response relationship curve. So however you can be able, but like tell the patient to rate, because we have some side effects as well. I prefer like 600 milligram, which is the midway between 300 and 600. Some of my colleagues would go for a 300, but like it's very rare if we go for the 900 milligram. Then we finished, our patient is in theater. Now we have to think about 4 things. These are the 4 critical points in anesthetic plan we have to think about. First of all is the airway management. Airway management in these patients, and I cannot strain on this point more. These patients require prompt planning to choose the technique which suits the patient, your expertise, and the facilities you have in the hospital. And some hospitals, and my hospital was one of them, has developed like a protocol to take a decision about these plans. And this is a very simple protocol. In fairness, it depends on 2 main points about the stability of the spine and the risk of aspiration. And it starts between using the non-depolarizing muscle relaxant or even going up to awake fiber optic, passing through the intubating LMA and sleep fiber optic as well. The other point is the positioning. And the patient position for spine surgery depends on the spinal level. For upper cervical, for example, we might use this on the top right corner, which is the Mayfield, which is, I find it more stressful and causes more pressure, blood pressure rise in the patient if you are not careful about that, more than the surgical incision itself. Or even using a roll beside that and leading to extension of the neck. We should be caring about these points. And for thoracic spine, for sure is the anterior approach, which is very rare now. We prefer using the posterior approach and lateral approach. I might not go through the whole risks of all these approaches and what's the nerve injuries possible and what's the lesions and what's the causes that will lead to that. We'll discuss more about the prone position, and I'd like you to ask you about the question about the prone position to see how we are aware about that. Which is most correct about prone position? Proning has always improved ventilation, perfusion matching. Prone position poses higher risk of nerve injury than the supine. Cardiac index improves by proning, which improves the VQ matching, or the jackknife prone position has less bleeding risk than prone position. Yes, I know it was a tricky question in fairness. The right answer is D, and we will talk to that. Proning position is not always improving ventilation perfusion matching. Some of patients we have, even in the COVID or outside the COVID, might lead to hinder the ventilation perfusion matching, leading to hypoxia in some patients. And prone position doesn't pose any higher risk for the nerve injuries more than supine. There is no evidence against that at all. And we discussed about the cardiac index that improved the proning. Actually, proning hindered the cardiac index by 12 to 24%. And we will talk about the study that reveals that. Jackknife prone position is the proper position now we consider, and that will be shown in the lower left. And that is the proper position for a lumbar disc now, for a single level or more even. And we have a study for that. We'll talk about the less bleeding. That's because it's lead to less abdominal pressure and compression. So let's talk about the prone position a little bit and about its effects. It's a common position and it affects the whole system. We are aware of, all of us, about the respiratory effect and its outcome and improvement of the VQ matching, helping with the ARDS and all of that. And that the pathophysiology is a little bit tricky. We were depending on the gravitational theory that explain the improvement has been proposed, and suggest the blood flow favors to go to the dependent area, which is a more better irrigated area now. But this study in 2010 was published, and they used an isotope scanning, CT scan for the lungs, and they showed that there is no change in the distribution of ventilation, but more, it's even distribution of the pulmonary blood flow, and that will lead to some sort of improved matching. So it's not the gravitational theory we can follow, it's challenged now, and there's a model based on the branching architecture of the pulmonary vessels and the airway has been recently proposed, and that provides an alternative which is more or less accepted than the gravitational theory now. For cardiovascular, yes, it's the effect of prone position. This is a study that was published 2006, and it's talking about the hemodynamic effects of the proning. And everyone has done a proning before. You know that the blood pressure will drop at this specific moment while we are proning the patient. And the cause for that might be the decrease of the LV compliance or the compression and the decrease of the preload. We are not so sure about that. It's not that clear yet for all of us. Cerebral blood flow, it might be hindered by the tilting the head to one of the sides. And we used to use that a lot to tilt the head. And we are aware about that congestion of the internal jugular, leading to a tilt or kink in the internal jugular with the tilt of the head. While the renal effect, they mentioned in a small study, including 82 patients, we're talking about improvement of renal blood flow to the kidneys as well. And talking about the other side, which is the complication of prone position. And this is a very nice systematic review discussing only the prone position. And surprisingly, they included about 53. And the most discussed complication of prone position was the postoperative vision loss, which is a very rare, it is a very rare complication. But it is very devastating as well, and we will discuss that in a moment. But other than that, the commonest to happen is the cardiovascular compromise. These are the most common, while as we said, the nerve injuries in the prone position is as well as supine position. And there's a study suggesting that even in the surgical nerve injuries is equal to the medical nerve injury. So the patient who is admitted, either surgical and medical, they have the same risk for the nerve injury, so it's not more for the position itself. And that's what we were talking about the jackknife positioning of the head, of the whole body, and that affects, it decreases, and they concluded at the end that it decreases less intra-abdominal pressure elevation and less surgical site bleeding as well. So, and they concluded that the jackknife position is the preferred choice. I know a lot of surgeons now is performing the single level and the multiple level in the jackknife position. Now, let's talk to the commonest mentioned complication. It's not the commonest. It's very rare. It's the incidence is 17 in 10,000, up to 1 in 1,000 in whole assessment. But it is very devastating. It is very scary for the patient and for the anesthetist as well. The major cause of the vision loss in the patient population includes either ischemic optic neuropathy or central retinal artery occlusion or retinal vein occlusion. And actually in the United States in 2012, they developed a group to study in the whole registry, on the whole American registry, and they searched for the all variables in all patients. And they concluded that there is some variables that may lead to increase the incidence of postoperative vision loss. So the non-changeable is that the male patient's higher risk, the obesity, and the patient with diabetes. But there's other factors that can be changed, which is the anesthesia duration. That's something, and estimated blood loss. And depending on that, they concluded the blood pressure drop and the requirement of more fluids. And that's what we are talking about. So in this position, and you can see the difference between both, we'd rather to keep the head at the level of the heart. And that we will come to these recommendations afterwards, rather than lower in the heart or higher. That is the safest way to keep the head, to avoid, decrease the risk of postoperative vision loss. So coming back to their recommendation, and they ask for precautions to be taken. They have a very low grade support, evidence support, but still, and what they ask is simple things like head position at the level or above the level of the heart, use of colloids and as well as crystalloids to maintain volemia, and maintain to the blood pressure within 20% of baseline. Anybody working in neurosurgery or in an orthopedic with a spine surgery know how important, and we will discuss that and we'll mention that frequently in fairness, and about maintaining the blood pressure in the same as the normal when he's awake. Monitor the hemoglobin and try to replace it if there is any significant blood loss. And the other thing is staging of long procedure when it's possible. So coming back to the other intraoperative complication now, we will discuss, and we've gone through that, and we'll discuss the monitoring within them. So first of all, I'd like to talk is the spinal cord injury. And spinal cord injury is very uncommon. It's about maximum, it will be 3%. The most important points we need to focus, it's not limited to the site of the surgery. It might be due to the poor positioning. It might be due to the low in blood pressure for a longer time. It might be at any level. And paraplegia, quadriplegia has been reported as a result of poor patient positioning. There are reports of patients with spine disease who suffered even injuries very far away remote, and we cannot attribute it at all to the surgery itself. If we kind of take a look about the blood supply here, and we see that the major vessel, which is the artery of Adam Wicks, and still the segmental arteries from the thoracic and lumbar region. These are very important, and we have to know about this. And they discussed about risk factors, and one of the risk factors I'd like to show to you is the sublaminar wiring and using of certain instrumentation, which is called look rod. And that's what I encourage my junior colleagues to be involved. And I know most of the senior colleagues are doing that, is to be involved in the surgery. They know the steps, they know what is going to be used and everything as well. On the other hand, you have to look to that and to see that conditions increase the risk is induced hypotension as well, or inadvertent cord compression by the surgeon or by some sort of instrumentation as well. And in Toronto University, they developed and published this in 2008, and this is talking about the perioperative spinal cord injury. And they outlined the treatment and management. I'd like to point to some points. The first point still is to maintain the mean at 80 millimeter mercury. We have a specific number, but we still stick to 10% of the individual. If we have a younger patient, but like we prefer still to have a higher one. A higher MAP is very favorable for these patients. Using of steroids it's not concluded, it's not proven, but still they recommend to do that and to take the precautions. And they ask for, and they added the need and the requirement of monitoring, either with the somatosensory evoked potential and motor evoked potential as well. And they outlined the treatment if that happens. And again, the recognition is the first thing, and to maintain the main. And I cannot strengthen more and focus more about the requirement of keeping the blood pressure above 80 in these cases when it's confirmed using of steroids. Yes, still some of the surgeons are still using the CSF drainage, and other will go for a systemic cooling, but all of these are not unproven, and they have a lot of complications and side effects that will encourage us to go for that one. So I'll ask you another last question about the somatosensory evoked potential itself and the whole neurophysiological monitoring. And we are all aware about the effect of anesthetic on these neurophysiological monitoring. But what do you think has the least effect? Is it ketamine, fentanyl, propofol, barbiturate, or nitrous oxide?
Okay, you have the results on your WhatsApp.
Oh, that's a good answer, yes. The most is answering about fentanyl, and which is the right answer. Actually, ketamine has an effect. We don't know if it's a simulation or inhibition, but it's sometimes these. And we're gonna discuss why we are talking about ketamine. While propofol as well, it has some effect, but we have some sort of control about these. And barbiturate and nitrous oxide as well has some effect. So the fentanyl is the right answer. So let's discuss about the neurophysiological monitoring. And once we mention that, two things that jump to my mind. First of all is the bile block. It's a very critical. It's a very important. Some authors would suggest bilateral bile blocks to be kept in the two molars just to avoid kinking of the tube. And the other point is to try to clear the body from muscle relaxant. We are not meaning to discuss rocuronium here, but yes, please do not try to clear the body at this point. You can use it earlier, but then you have to be sure that we are clear on board from the muscle relaxant. Types of neurophysiological monitoring, and its function is to assess the integrity of the structure of the neurons itself and the whole neurological pathway. We have different types, and every type will measure specific areas in the neural system. So, for example, the somatosensory evoked potential will check the whole afferent neurons coming from the body to the brain and to the spinal cord, while the motor evoked potential is the opposite way, measuring the EMG as well. It's sometimes be used to assess the junction in the neurons between the neurons and the muscle, while the brainstem and the transcranial is not used frequently in a spine surgery. It's used more in brain surgeries. And if we're going to talk about the somatosensory evoked potential, so the goal of the whole intraoperative neuromonitoring is to identify disruption in the nerve signals quickly so that surgical adjustment can be made before the spinal column configuration is set. Specialized spinal cord function monitoring can be achieved measuring evoked potential. One of them is somatosensory. And satisfactory monitoring of these is possible still with a MAC between 0.5 and 1 in isoflurane, desflurane, or sevoflurane is the most common method to use. And the most important thing that is a reduction in the amplitude of 50% or increase the latency by 10% would be considered significant, and we have to mention that. It's affected by the temperature, it's affected still by some of the anesthetics. We're going to discuss that in a moment. But we have to focus about this point. Post-operative neurological deficit can be found, can be reported even the normal of SSPs, and that is very rare, but that's what leads to development of the motor evoked about the motor evoked potential. If we're still talking about the somatosensory, that generally affects the intravenous effects, is generally affecting the somatosensory, but less, far less. Ketamine and etomidate increase the cortical somatosensory amplitude, while nitrous oxide. We'll jump to the next slide showing the effect of the whole inhalation anesthetics, the first three, and how they are affecting more than the propofol and the benzodiazepines, but while the whole opioid doesn't have the effect at all. And that's what causes us to tend to use more of opioid anesthetics in this, using remifentanil infusion, for example. And the motor evoked potential is the same thing, but inhalation anesthetics inhibits the myogenic MAP in a dose-dependent manner, while moderate doses up to 50% have been successfully supplement other agents during the MAP monitoring. So we can some sort use the inhalation. We are not preferring that. We are trying to avoid that the maximum. But if we are stuck, we can use that, and we are in some situation. The next complication we're going to discuss is the intraoperative blood loss. Significant blood loss and complex spine surgery is something common. Some of the studies mentions up to 2.8 liters of blood being lost as an average, which is a scary number, but still might happen. And we are aware about the blood transfusion complication, either immunogenic or not, or infectious, but we're definite just to mention that blood transfusion may be associated with increased risk of postoperative infection. And these patients have high other causes, like a huge incision that might be involvement that will lead to that risk. And we are trying to avoid risk of the nervous system by any means. And just that's to mean as well, the blood transfusion has a cost on our system, on our health system. We are coming from countries that we work in a country that health system is not properly funded yet. So the cost of blood replacement must be considered. And in a recent cost analysis, a benefit analysis study, the average cost for cell saver was about $512, while auto transfusion is replacement up to $250. And just to discuss, some group tried to develop a predictive module for who patient will receive the blood and need to proper investigate his blood. And they reached that the age group more than 50 with a lower hemoglobin, which is accepted. But a transpeduncular ostotomy has the same scoring number with all of the other criteria, which indicates the importance again of being involved in the procedure itself. Now, for the last for the question about the conservation of blood, we go for that, and which intervention helps in blood conservation? Is it aprocitenine, magnesium sulfate, regional anesthesia, or controlled hypotension? or epsilon aminocaproic acid. So the magnesium sulfate is the right answer. We cannot prove, and I have seen that the maximum answer about the controlled hypotension. We are not using a controlled hypotension. The doesn't have any proven evidence about the benefit of the patient, and it again, we are trying to avoid the blood pressure at the high level. Epsilon aminocaproic acid has still a controversial studies, and it doesn't, but the magnesium sulfate in fairness has shown the benefit about that, and that was answered in this article published that's published in 2010 about the blood loss, and they discussed the whole way and they studied the whole other ways, and just to go through them. So discontinuing aspirin doesn't have any effect about the bleeding. In contrary, all the surgeon would ask the patient sometimes, but like if patient on aspirin, please don't stop that. Erythropoietin might cause some reduction in the requirement of blood transfusion, while autologous predonation doesn't have the same effects. About the intraoperative pharmacological antifibrinolytics, use of the antifibrinolytics, and I hope we are all aware about the CRASH-2 trial and CRASH-3 trial, and how the benefit of the tranexamic acid is used for the reduction of the blood transfusion. It's one of the proven with the high evidence supporting that. Magnesium sulfate, although it has a moderate level of evidence, but it still shows some sort of that. Regional anesthesia-induced hypotension is very low, and optimized prone position as well, as was shown in the jackknife positioning study, shows the same answer. And intraoperative blood salvage, and the surgical technique and the staging of the operation has proven to be helpful as well, with a very low evidence. The last question for the last important and very important, sorry for that, Walid, I know I'm a little bit late, about the post-operative analgesia, which is a very critical and very important as well, with some points. So paracetamol has proven analgesic effect post-operatively, and so a non-selective COX-2 inhibitor has more potent effects than selective. Preemptive analgesia using gabapentin has proven post-operative analgesic effect, or local anesthetic infiltration is the most effective analgesic intervention.
Five more seconds.
Yes, we're getting a right answer now with the 50% still. I know it's a little bit conservative. It's a little bit difficult to answer, but prove paracetamol till now, and this is one of the questions that I still have in my mind. I cannot answer. There is no studies. Studies tried to prove that, failed to prove his efficacy, while non-selective COX-2 has less potent efficacy than the selective one. Yes, and preemptive analgesia. We'll jump a few bit slides about the antifibrinolytics, and we're gonna discuss the analgesia for complex spine surgery. So multi-level spine surgery might require very intense perioperative pain control. You don't like your patient to be converted into a post-operative pain, chronic pain patient. And there's a systematic review just discussing all of these points about what to use, and it shows it had included the whole trials. It's a very brilliant. It was published in October 2019 in the Current Opinion in Anesthesiology. And one of the things that I'd like to mention is one of these is the perioperative intravenous ketamine for acute postoperative pain in adults. I remember when we were discussing that we cannot use that with the neurophysiologic monitoring. Yes, and with these patients, we tend to use it after we finish and we confirm everything, or even in the post-operative period, because this is one of the brilliant systematic reviews and meta-analysis has been done, and it includes about 130 studies, with including about more than 8,000 patients, and it concluded at the end that post-operative and perioperative ketamine infusion reduce all the analgesic requirements and opioid consumption as well, and improve the outcome of these patients and the requirement of opioid and its complication. The last point I'd like to discuss is the extubation. Most common causes of admission for ICU for spine surgery is failure of extubation and requirement of ventilatory support. Airway facial edema is very common to happen during the long procedure with prone position, so that will be very difficult. And the incidence of airway compromise requiring re-intubation after anterior procedure, it might go up to 2%. You have to have a plan for the airway compromise, how to do that in a stepwise, and how to perform, and at which level you have to re-intubate and transfer the patient either to the operating theater or even for a tracheostomy for these patients to do that. Just to summarize at the end, airway management is a critical point. Airway planning as well for these is very important. Anesthetic agents and neuromuscular blocking affects neuromonitoring in some controlled way with some medication, but we have to consider that as well. Blood loss may be significant or even massive for some spine procedure, and you have to think about planning and plan for the blood conservation and the blood transfusion as well. Positioning, and care about every single step in positioning your patient from head to toe, from abdomen and for his chest. And the post-operative visual loss is important, a rare, a devastating complication. It might happen to any of us, so we have to take a good care about that. And thank you very much, Walid.
Perfect. Thanks so much, Dr. Amr. Allow me, first of all, to express my warm thanks and sincere gratitude for all our colleagues sharing with us today their expertise and knowledge. Prof. Salwa Al-Khattab and Dr. Amr Salam. I will put the first assessment of the first lecture here now while we are running a few questions with Dr. Amr. So this is your assessment and attendance sheet for the first lecture from Prof. Dr. Salwa Khattab. And the first question, Dr. Amr, is gabapentin is continued post-operatively or only just single dose in pre-operative, and that's one dose only?
The network meta-analysis discussed only the single dose, while other studies discussed it using pre-operatively. But we prefer to continue that post-operatively as well, and there is no significant, there is no important studies has been discussing this point a lot, because that will lead us to a lot of statistical problems. But in fairness, in my institute, it's a protocol to use a gabapentin pre-operatively and post-operatively as well for about 3 days.
Perfect. So another question from the same colleague. Recommendations before wake-up test. What should you do before waking up the patient for wake-up test?
Wake-up test, we didn't discuss that. Yes, wake-up test is the oldest and the surest test to test with that. The first point, you have to discuss that with the patient. This is the first important and critical point. You have to explain to him every single step in the pre-operative assessment clinic and in the morning of the day. So, and you are clear about there is no, and the neurophysiological and the neurophysiologist will clear that we are no muscle relaxant as well, and then we'll start to awake the patient, and we will prepare him before that about which limb he will move, and we'll ask him to move his limbs, and then we'll give him some sort of we'll start again the anesthetics and use that. But the most important thing is to discuss that to the patient and to explain to him. That's very clear as well.
Perfect. So I have 3 questions I will put all together here. They're all about pain management. So what's the dose of magnesium sulfate and the protocol of ketamine infusion post-operatively? And is there any contraindication to use the gabapentin?
I'll start from the last. Yes, there is some sort of contraindication. moderate to severe renal failure is considered some sort of contraindication. We can modify the doses. Suicidal attempts and myasthenia gravis, I think, is the contraindication, the clear contraindication. Other than that, there is nothing clear. About the magnesium sulfate, it's not clear, and a lot of people using different doses. Some will tend to go for 2.5 gram as a bolus during in the intraoperative period, just to help with the bleeding and the postoperative pain as well. And where some will recommend like a dose of 0.01 milligram per kg as a postoperative dose infusion with a close monitoring for the reflexes and the level. While the ketamine infusion, it has different models, and we go for 0.1 milligram as a bolus, and then starting with 0.01 milligram per kilogram per hour. That's over 16 hours as an infusion as well.
Perfect. So is steroids given routinely for prophylaxis for facial and airway edema?
It's not. I didn't. So what we're gonna use? We are not using that. Facial edema is something mechanical. We are trying to avoid that by mechanical. I don't think steroids will help a lot. I don't have any evidence supporting this idea, and I cannot explain, or I cannot rationalize that giving steroids to the patient for a facial edema that will take hours just to be resolved. I think we'd conserve the steroids for something more critical rather than the facial edema.
I have seen it used for airway edema in severe laryngeal edema post-operative, but in facial edema,
yes,
I didn't see
I
that.
totally agree with angioedema or airway edema, yes, but like with a facial edema, just facial edema, we didn't try it.
Okay, what about lidocaine infusion for analgesia from your point of view?
Lidocaine infusion is controversial still. There's some evidence supporting that. Some of my colleagues are using that, and we are using lidocaine infusion for chronic pain. But to use it with the high concentration and the same doses we are using with chronic pain, that would be too massive, and that might be a little bit require every single patient to be monitored for a longer time after the post-operative period. And giving that with all of other, sorry for that, and giving that as well as a medication, and with no support, like strong support evidence to support that, I think it will be a little bit more aggressive as well.
Perfect. So we're going now for the second poll to assess the second lecture of Dr. Amr. So kindly start voting for that. And the last question is here by Dr. Hani Abdelgalil. Is there any value for acute blood loss for transfusion in scoliosis surgery? And what about euvolemic hemodilution and autologous blood transfusion? What do you think about each of these?
Can you repeat the first part of the question again, Waleed?
So is there any hemoglobin cut-off for blood transfusion in the acute blood loss setting in scoliosis surgery?
In fairness, I'd like you to ask you that, Waleed. We don't have a cutoff. Like we have the restrictive people who would say, yes, we allow the blood loss to be 7, and I don't know why it's 7, why it's not less, why it's not higher than that, and 10. We don't have a cutoff. We depend more for the acute loss, to replace the amount of the blood. We have the maximum allowable blood loss for this patient, and we'd replace after that.
I think, Amr, like it goes with the common sense, and be vigilant if the bleeding is like horrible and you can see that the surgeon is struggling to control the blood loss intraoperatively in a surgery like scoliosis. Don't wait until 7, because he will reach 7 sooner or later. So go for blood transfusion as soon as you can. But if the surgeon is confident enough that he's controlling the bleeding, which I don't think this is a scenario with scoliosis most of the times. So if we find a bleeding patient, don't wait for certain figures, just your hemovigilance, and it's all together. Like you look at the hemodynamics. If the patient tachycardia, or you are on a high dose of NORAD or phenylephrine, this is the time you transfuse, even your patient is not tachycardic because you are blunting his sympathetic response for tachycardia.
Yeah.
I think it's like there's no right or wrong answer or black and white in this regard. If you agree with me.
We'll try to be vigilant, as you said, and we are trying the maximum not to give the patient the blood. But at some point, we need that. With the scoliosis, with other surgeries, the bleeding might be so frank; it might be like more an ooze or something like that. And as you said, we have to use our common sense, and that's why we cannot use an artificial intelligence in our practice. Still, we are keeping that for the human. For the normal volemic hemodilution and the autologous donation, I don't think about it. The last evidence hasn't shown a massive effect about that. Preparing these patients for that with a cost it will cost more than €1,000, and we don't have the support evidence to support that. It's helpful. I prefer for myself, if I'm going to get a blood, to get my autologous blood, but still, you cannot consider that as a common practice or protocol in your institute, I think.
Perfect. So by this question, we ended the discussion, and we would like to close the session with Professor Dr. Samir Al-Ansari. And if Prof. Salwa wants to give us a word before leaving, she's the first time here with us tonight.
Thank you, Dr. Walid. Thanks, Dr. Salwa. Thank you, Dr. Amr.
Thank you very much.
And highly informative 2 lectures. And I agree you, ketamine now is proved totally as a potentiating effect for opioid analgesic, and it is used to potentiate analgesia in post-operative period. Also, in addition, it has antidepressant effect and may continue for 6 months, up to 6 months after just a few doses, 2 doses or 3 doses from ketamine. Really, thank you, Dr. Amr, for this.
Thank you very much.
Really, I am enjoying with it, and Dr. Salwa lecture. Dr. Walid, I think Dr. Salwa lectures needs to be divided into 3 lectures. To be
Definitely. I didn't believe that it's gonna finish in 30 minutes or 40 minutes.
I was surprised for Samir is telling only 5 minutes, almost half of it.
After pushing from Dr. Walid, really, not from me. Thank you, Dr. Amr, for your
very much.
Nice lecture.
Prof. Salwa, do you want to give a word for the attendees tonight before leaving?
Enjoying very much these webinars. I'm thinking COVID put us to be online together so we can share our experiences and like that. And I need to confirm that success, I will be back to my topic, management of acute kidney injury is a multidisciplinary approach. Please keep in a multidisciplinary approach, and I'm thinking we might have different, maybe another topic about that, especially in my colleagues' clinical pharmacy. Clinical pharmacy is adding a lot to my career, the discussion and everything. Thank you very much for making this arrangement, Dr. Walid and my professor, Dr. Samir. It's a pleasure and it's an honor to be with you. Thank you very much.
Thank you. Finally, I have a lot of requests here from you, Prof. Salwa. Please, we need another lecture from you. So I promise that there's 2 more lectures for Prof. Salwa. So you will see her again and again. See you next week, Saturday, 29th of August, 9 p.m. Cairo time in the 11th week. We'll keep you updated with the lectures coming all the time as usual. And please don't forget to visit www.savinglivesacademy.com to find all the previous lecture recordings, and keep in touch. If you have any questions, we can deliver always your questions to our guest speakers and professors. Thanks very much, and see you all back next week. Assalamu alaikum.